Good afternoon, everyone, and welcome to today's webinar hosted by Region 8 chapters of HFMA. The topic for today's webinar is Data Analytics, a Strategic Approach to Market Performance and Service Line Profitability. I'd like to welcome today's guest presenters. We have Derek Pierce, Eric Rogers, and Todd Kenny, all of BKD. BKD is one of the largest national CPA and advisory firms in the United States, with 36 offices in 16 states, and works with approximately 3,900 healthcare providers nationwide. I would like to introduce Todd Kenny, a partner out of BKD Kansas City, Missouri office. Todd is a member of the BKD National Healthcare Group and performs audits and consulting services for healthcare and not-for-profit organizations. He is a fellow of HFMA and the current president of the Heart of America chapter. I'll now turn the call over to Todd to get the webinar started and introduce our other speakers. Todd, please go ahead.
Great, thank you. Good morning. Thank you everyone for joining us for this webinar. Like most of great webinars you probably heard, I wanted to start off with a quote. This one is from Charles Darwin. Is not the strongest of the species that survives, nor the most intelligent, but the most responsive to change. I think that's very relatable with healthcare today. Just the list of changes in healthcare on an annual basis can be mind-numbing. The industry continues to see changes in volumes, such as procedure shifts from more to outpatient from inpatient, due to changes and advances in technology and pressures to reduce costs. There are also changes in consumer behavior through the use of the insurance exchange products, or just with the increasing number of employers who now offer the high deductible health plans in the market. Individuals are changing the way and how they receive their services and the timing of those services. In addition to volume changes, you'll see there are also increased costs for physicians, other labor and services. Obviously, information technology costs are continue to increase, and the cost of drugs, is frequently headlined in the news. So really, at the end of the day, due to all these shifts, many healthcare providers are getting increased pressures on their overall margins. One of the many ways that to help assist organizations to make better business decisions and where to focus on is appropriately use their data to understand how all this change in the volume and cost is actually impacting their organization. Your organization may have lots of data, but how you use that data to create information that will be beneficial to your organization is really the key to that. So this brings us to our topics today of using your data to develop information on how you look at your strategic approach to the market, maintaining your volumes in reacting to that, and also evaluating, the service lines and the profitability to your organization as those volumes and the different services change. So our first speaker I'm going to turn over to is Eric Rogers. Eric is what I've dubbed really the Medicare data guru at BKD. He's a member of our BKD Healthcare Performance Advisory Services Group. He's the thought leader really driving our healthcare data analytics efforts and our Medicare market assessment. He focuses on using data to identify opportunities in volume and market activity that allows organizations to better ask questions regarding their overall market strategy. And then after Eric, you will hear from Derek Pierce. Derek is a member of our BKD National Healthcare Group and a partner in the Little Rock, Arkansas office. He will discuss today an analysis that he created using the Medicare cost report as a base to develop a cost-efficient and effective approach to analyze an organization's profitability and their margins, looking at both the service lines by physicians and clinics, really allowing organizations to better focus their efforts when they start looking at cost reductions and other operational changes. So with that, I'm going to turn it over to Eric to get this moving.
Hey, thanks, Todd. Appreciate it. Again, we welcome everybody to the webinar, and we look forward to sharing with you some of the work that our health systems have been doing, some of the work that we've been assisting them with, and giving you some ideas, some thoughts, some considerations that hopefully are applicable to your organizations. And again, as it relates to dealing with the change that you're facing and trying to manage a healthy business that delivers healthcare services. From from a context of data analytics. And so as we get into the presentation today, what we're going to look at is a few stops along the road. We're just going to talk about the expansion of data in healthcare, and then I'll talk specifically about using and looking at external data and how that has assisted organizations in the past and how it is shaping future strategies in terms of developing your market, whether that means reaching out to independent docs to employ them or do a joint venture or co-management arrangement, whether that means looking at other hospitals to align with, or purchasing a rural hospital or a critical access, using data to make good business decisions. But it also helps you understand what business is going on in activity at your hospital that may be leaving the system and going to your competitors. And then kind of the drill down to answer the question of why. And is it a modifiable thing that we can impact or change the way that we integrate and align with our physicians? So that'll kind of be a focus all on using external data to make your organization stronger. And then I'll turn it over to Derek and have Derek talk to you about using internal data in a way that you may never have used it before, or an approach that you haven't used before, to really understand what's going on at a service line level. So let's start through these three items. We want to keep it pretty simple and straightforward, and then we'll field some questions toward the end if you have those as well. So the first thing that I wanted to begin the discussion with today is understanding a little bit more about the expansion of the data and what we call a maturity model. And it is developing and growing. I'm a father of 2 kids and a third one on the way in about a month, and I feel like I've got a maturity model going on at my house, watching my kids grow up, and they change and they get smarter, and their vocabulary grows. It's just the same with healthcare and data. It's constantly evolving. Sometimes it surprises you with the things that it shows and the pictures that it gives, and you've got to constantly stay on top of it and be involved in the process rather than the process taking over your lives. So this is our maturity model for data and where it's been in the past and where it is headed in the future. And so starting from the left, really this is an area that hopefully we are working hard to move out of. If we're still in there, it's really the first phase, and that's the fragmented point solutions. This is that ineffective, inefficient, inconsistent versions of the truth. It's generally a vendor-based approach where we may third party out to multiple vendors to pull together analytics, and that includes both internal and external. One of the things, I'm a former hospital administrator of a 2-hospital system, and we had a fragmented solution in a lot of ways. And one of the things that always seemed to creep up in terms of data analytics was what I called the report of the day. And that was, the quality leader. We had a nurse that would want a specific report to be run so that she could submit data for meaningful use. We had a radiology director that wanted to look at utilization of his CAT scan machine that we had just purchased. And so all these department leaders kind of popped up, and they all had their interest about running reports, internal and external. And we were just chasing our tail trying to figure out how do we manage all of these reports that come through and the processes of controls from that. And it was a very fragmented solution, including inpatient versus outpatient. And so one of the ways that people began to move out of that was developing, a enterprise data warehouse, or an EDW. In the past, that was just a big, huge sandbox where all data was dumped. And so we could go to that kind of like a supermarket and go shopping and find the data points that we wanted and put them in the cart, go to the checkout line and run that through a a solution or a tool to analyze that, like ACL or Excel or some other program. And we just had this big warehouse full of data. But the problem with that is you may not only use but 10% of everything that gets thrown in there, and you've got to pay for all that storage, and then you've got to maintain it, and a field changes in your EMR system or something with the payer. And so constantly managing that monster of a warehouse just became unrealistic in a lot of ways. And so we needed to continue to evolve past that and have more of an on-demand service. If you're a Cerner or an Epic shop or some of the other big EMR vendors, they now offer EDWs as a part of their solution. So things like Healthy Planet or Healthy Intent. Those are systems that serve as an enterprise data warehouse. They gather EMR information. They can gather information from Kronos or Midas for your quality, Omnicell, maybe GE information from your radiology department, and pull that all in and try to have population health tools or other places that you can derive business intelligence reports out of. From there, it really becomes important to focus on managing that data and defining things appropriately and coming to a standard vocabulary. So for example, how do you define observations and your inpatient status and your observations and outpatient? How do you calculate your observation hours and make sure everybody comes to an agreement on how you calculate and name things? Otherwise, you're going to have a lot of version confusion. And then on from there, we have automated internal reporting, which I'm sure many of you have some of those for staffing, length of stay. Maybe you've got a focus right now on observation in a bed or major length of stay issues. So you've got all that internal. Todd is going to get into that internal a little bit more on how data can be used from that perspective. The next is external. So we've got to gather data, and sometimes we've got to send data out to an external source. Maybe that is your meaningful use data, PQRS, your hospital value-based purchasing, or now MACRA data. How are you gathering all that and sending it out? One of my favorites and where things can really get exciting is waste and care variability reduction. This is clinical efficiency at its best. How do we do value stream mapping of the data and understand what our processes are to improve processes, throughput, workflow, but also supply costs? How are we gathering and looking at how Dr. A uses supplies and staff versus Dr. B, and then compare the results of that to say, let's define best practices and new care pathways that save money internally for our organization. The population health has been a big driver of a lot of the use of the data. So ACOs, bundled payments, your CPC Plus programs, there's a lot of activity going on right now in using that data. The last two steps are the furthest maturity of the data, and one is using all kinds of clinical information like ICD-10 codes to evaluate and increase propensity of patients for readmissions or other things like that. So that's using data to predict outcomes and to try to get in front of those before they happen. And then finally, it's not going to be long before we're moving into an area of using genetic data. So take a blood sample and do a genetic testing and finding out, what am I predisposed to? Maybe I have Alzheimer's in my family. Do I have a gene or an allele and a marker on my chromosomes that predispose me to that? And what can I do to ward some of those things off that are modifiable, whether it's through medications, whether it's through lifestyle choices and habits and healthy things like that. So that's kind of the start to finish maturity that we've seen from a lot of providers. The trends, though, are common. The content will expand. The timeliness will increase. You're going to need to have increased governance and control structures over data at your organization so it doesn't get out of hand. And then the complexity of the binding data and the algorithms will also increase and make it a challenge. So there's an example right there. We won't go through all of these, but that may look familiar, of expanding data content from billing to lab and to an HIE, cost accounting data, which is what Derek will get into. But, you know, you've got your UV forms. I used to work in CT and MRI, and we did scans of the aortic vasculature of the heart, which is down below. How do we use that data to solve problems clinically? We've got our EMR. We've got Google and Apple Watches that now track all this information and help us move on. So it's going to continue to expand. So what are you currently measuring at your organization? Externally and internally. What I'm going to do is walk you through some examples of some external data to look at and consider. And some of it you may already be getting a lot of this data through your state hospital association or otherwise, but it's a good source for planning efforts and work at the hospital. And then I'll turn it over to Todd to get into some of that internal data and really drive the market there. So I'm going to bring my screen down here, and I'll pull up another source that we can look at for just a moment. So this is an example of using external data. And so this is all Medicare claims data. That's one of the things that is a firm that we use and we analyze quite a bit, is Medicare has allowed us to purchase from them on a quarterly basis all Medicare claims data for every beneficiary in the United States. And we thought it would be good to get into a deeper dive of what's going on in markets. So as you can see in the map over here, this is up in Vermont. Take this as an example. We can identify every Medicare beneficiary who lives in Rutland County, Vermont, and find out where are they receiving their inpatient care. Who are the services? How many people are leaking for inpatient business? And how has that trended over time? So provider 1 used to have 23% of the market. Looks like they've maintained pretty steady, but this orange one here has grown over time. But then you get to the service line leaders, and they want more specificity. So I want to break this down to, maybe it's just a service line, orthopedics. Let's say if I'm just really curious about what's going on with all the orthopedic business, I can filter simply in one click now every inpatient business to only look at orthopedic claims. And the map looks a lot different. Now that one provider has a significant portion of the orthopedic business for that entire market. But that orange provider is not nearly as high. So you get a deeper dive into each of the service lines. But yet, some providers won't say, I want it all the way down to the individual DRG. And because it's on a claims data, because you can harness the power of the data to a deeper level, you can drill that all the way down into a specific DRG, like 469 or 470, to look at that activity and that volume by an individual provider or an individual doctor or service line. So, for example, now I can only see at the service line if I want to look at all of my pneumonia patients. Now we can see how effectively we're maintaining and managing all of that business for pneumonia. So it's a great way to consider that external data, is to look at your market on a detailed level. Another way that a lot of people have been using external data is to assess what's called the RAF score. So the risk adjustment factor. This is based off of diagnosis codes that the physicians document. It's tied to the HCCs, and that's what Medicare Advantage uses, and it's what the ACO programs use. So is my hospital, for my patients, are they sicker or healthier than my peer hospitals around? And if I break things down by individual service line, so again, if I want to look at just cardiac or ortho, I can compare, all of my patients in my case mix and find out for other hospitals that are of similar size and structure, is my case mix for orthopedics higher or lower? And if I'm in the bottom 25th percentile and I move it up so that I'm in the 75th percentile of case mix for other peer hospitals, what does that translate into dollars and cents? So a severity adjustment is going to continue to grow as an important data aspect of evaluation. You can also look at how your patients are coming in through the ED, through elective, or how are they being referred through the organization. So those are all good things. Of course, everybody loves to benchmark. And so, for example, I selected orthopedics here. Each of the providers is a hospital. I want to know how I'm doing. What is Medicare paying me for my orthopedic business? If I'm thinking about cost control and value-based care. But in a fee-for-service world, how am I doing on my length of stay compared to other providers on a particular service line? And how has that trended over time? Same thing for readmissions and mortality and other matters that are important to us. Here's a hot one that a lot of people really like to use external data on, and that is looking at physician referral patterns. So because data is out there, and for example, this is what we use on the Medicare side, is we can take that data and look at, up top, these are all the individual hospitals that may be in a market. If I want to look at clinics, let's say that there's a large primary care clinic here, and I grab the tax ID number of that clinic, then I can see all of the individual doctors down here who are a part of that clinic and their activity and their taxonomy. Are they internal medicine? Are they a specialist? And then whenever you select individual providers, the ability to understand where those providers' patients are going to for their inpatient care. So it's a great way to measure and look at referral patterns and loyalty of providers, especially whenever you make a lot of investments to bring these doctors on. You want them to use your services if they're the highest quality and the best services around. So there's also information on inpatient charges, ED utilization. How are people utilizing our emergency department, and where are we discharging them to? Skilled nursing, home health. In a risk-based world, hospitals will be financially accountable for the post-acute care activity that occurs. And so you need to know who are the good skilled nursing providers, how long are they keeping patients, what's Medicare paying them, who are the good home health providers, inpatient rehab, and so on. So data is becoming more and more of an important area to track and follow care. Same thing for the outpatient. This is all inpatient, but using outpatient data, we do that quite a bit, and it's something I would recommend to look at where all your tests and procedures are going for outpatient side. So we found a lot of our clients really enjoy using data, using good optics as well to get it into a visual format that engages the C-suite, it engages the physicians and the board to be able to make good business decisions. So with that, I'm going to go ahead and turn it over to Derek and let him talk about how he uses internal data to help out his healthcare systems.
Thank you, Eric. Thank you, Todd, Nikki. Yes, and you know, as we turn from Eric's discussion about external data, you know, to looking at internal data, you know, it's important to keep in mind the context of why this is so critical at this point. And my first couple of slides kind of illustrate why now it's even more important than ever for hospitals to be able to use data to ensure their financial position. And obviously a lot of it starts with the payment reform that came out of the Affordable Care Act. You know, those payment reforms continue, the transition from paying for volume to paying for quality. And you know, for a long time, healthcare as an industry has been somewhat insulated from a lot of the economic realities faced by most businesses in the United States. And as the kind of financial screws get tightened from a federal reimbursement perspective, the ability to compete and understand your internal costs and operate more like a real business becomes that much more important. And why, while the Trump administration recently has kind of taken its foot off a lot of the reform impetus, we just heard last week that the chairman of the House Appropriation Committee expects there to be further cuts in discretionary health care spending. So this continues to be a very pressing issue. The next slide kind of talks about specifically the paying for quality instead of volume, and this specific type of reform is really important for hospitals to think about, because not only are you getting your reimbursement reduced, but under the old methodology, the fee-for-service methodology, the payment basically accompanied the service or whatever was utilizing resources. And if you're getting paid for the service, then your costs aren't really that critical because the reimbursement's aligned to them. But when you transition to paying more for quality, there can be a disconnect between your resource utilization and your reimbursement. So under that methodology, it becomes even more important to understand what your true costs are. And as Medicare focuses on which providers are costing it money, hospitals must understand which physicians and which service lines are costing them money. And while a lot of larger urban systems can afford the very expensive cost counting systems, community hospitals generally don't have the same visibility into their costs. But there are some less expensive approaches that can help fill that knowledge gap. Specifically, every hospital completes a Medicare cost report, and those cost reports are filed under very specific cost finding guidelines that can serve as a starting point for a cost counting system. And fundamentally, it's based on the relationship between costs and charges at the departmental level, including employee costs, supplies, equipment depreciation. You've got an example here for radiology. If your total costs in your radiology department are just over $9 million and the charges are just under $50 million, you get roughly a 0.18 cost to charge ratio. You can use that to compare the relative resource utilization between various patients. Your charges don't have to be 100% rational for this to be useful. They just need to be relatively, they need to reasonably represent the relative resource utilization within each department. So it doesn't matter if your drugs have much different markup levels than your PT charges, but as long as within each department the varying charges relatively represent resource utilization, this will give you usable data. So this approach starts with the departmental cost charge ratios and individual charges by patient. So you get very large data dumps for all your patients and all the charges for each account. And from that you can get your estimated cost. Using the cost report provides some additional flexibility that can make the results even more meaningful. For instance, your cost report includes both overhead costs and revenue generating costs, and for a lot of purposes it's better to know what your contribution margin is, which is the margin that excludes overhead allocations. So we can actually back off the overhead allocation from the cost report and recalculate the cost to charge ratios to give you a direct cost to charge ratio. We also know that Medicare doesn't allow you to claim a lot of costs that are necessary for the provision of health care. Certainly in today's environment, physician costs are incurred by hospitals and are excluded from the cost report, but we can add those back so you get a full picture of the resource utilization. And then we apply those cost charge ratios, both the direct cost charge ratio and the indirect, that include all costs, not just Medicare allowable. We can apply those to each patient account and understand how that rolls up both by physician and by service line. And we can calculate a margin by bringing in actual collections on those accounts, not trying to estimate revenue based on the contractual adjustments recorded, but actually look at the collections on individual patient accounts to come up with a true contribution margin. One area that many hospitals have a keen interest in is the cost of their implantables. And we know that's a significant cost for a lot of orthopedic work, and we can actually look at the individual implantables used on individual cases and use the actual cost for those rather than a cost derived from overall cost charge ratio. So we can get specific with that area. And we're all financial people, and it's important for us to understand these results as it compares to your P&L. So you can take the results of your service line analysis and reconcile it to your bottom line so that you have confidence that your data is right. And this slide just illustrates what that reconciliation might look like. So this type of project involves a lot of data. It can output a lot of data, and one of the important things to be able to do is understand how to use that data. And the next couple of slides illustrate how that data could be used. This image here is a web-based interface that we use to interact with the data, this view shows the service line by descending revenue, and it shows your cost and your margin percentage. And you might look at this every week and or every quarter, and maybe you notice that your cardiology service line had always been your top performer, but now it's kind of sunk to number 4. And not only has the revenues declined, but also the margins down. And you might wonder why that is. Well, you can drill down into this data and get some answers. Say you have 2 primary cardiologists, and this is example data from a hospital we've worked with. 2 primary cardiologists, and this view shows their costs in green and their revenues in gray over the last 2 fiscal years, broken out by quarter. And you can see physician 1 over the last 3 quarters has seen a significant reduction in his revenue and a less significant reduction in his costs. So not only are his revenues down, but his margin has gone from almost 30 to below 20, whereas physician 2 over the same 3 quarters has shown sustained stronger performance. So it can help you identify what area to potentially review a little more closely. You can drill into physician 1's claims for the period. What type of claims are now showing reduced margins or lower reimbursement? What DRGs is he or she underperforming on? And you can go further and look at individual accounts. So you see it's a certain DRG that looks low, pick a couple of those, and you can see, well, maybe he's using a different type of stent. Maybe he's using a more expensive stent now and doing less of them. And maybe that's a conversation that needs to happen there. So that's kind of an illustration of how you could use the data. One final illustration of the use of the data is to assess your enterprise value. A lot of the clients I work with have been trying for probably years now to convince their boards that their investments in physician practices is worth it. And this presentation can help support that assertion. This marries up the contribution margin that we just kind of walked through how to calculate on the hospital business with what you see on the clinic activity. This schedule shows, we know since the clinics are kind of discrete operations, we know what our revenue and our direct clinic expenses are. And typically, as you can see in the third column from this example data, they're usually negative. Certainly when you add on some overhead allocation that clinics can get in the cost report, the margins can be significantly negative. But that's obviously not the full picture of the financial impact of those physician relationships. And in the second to last column in this table, we can show what the physicians associated with each one of your clinics does on the hospital side. We can, there are significant contribution margins provided by these physicians in the hospital business, and when you compare that to the clinic margin, you can see what which clinics really need to be worked with to figure out how they can contribute more to the overall system, and which are our top performers. So those are two different ways to use this data, and there is an ability to drill down within a clinic to look at each individual physician within a clinic to know what their individual contribution is. But at least I know in my client base in Arkansas, many community hospitals have not had this type of information and have been kind of flying blind. And as I kind of went over initially, in today's environment, you just can't really do that and expect to be successful. So this approach allows a lot of smaller hospitals, medium-sized hospitals who might not be able to afford potentially a six-figure sticker price for a full-blown cost accounting system to get reliable data in a much more economical fashion. So I think the ability to use this approach matters more now than ever. And with that, I will turn it back over to Nikki with any questions.
Awesome. All right. Well, thank you, gentlemen, for that great collaboration. Before I take our first question, I would like to just remind everyone to type their questions into the questions panel located to the right of your screen, and we'll take, excuse me, as many as time will allow. I will address one question about the slides and replay. So this has been recorded and will be made to the attendees post-event. And the slides, no need to wait for that. You can get access right now just by expanding that handouts panel to the right of your screen and selecting that PDF icon. All right, so it looks like we have a question that may be geared, maybe directed towards you, Derek, and it reads, what are some of the most significant challenges in completing a service line profitability analysis?
Sure, thanks, Nikki. That's a good question, and I think most people, when we first start talking to them about doing a project like this, assume that the biggest challenge is going to be getting the data necessary to do this. And while it certainly is data intensive, the nature of the files themselves is not that difficult to pull out of accounting system. They're flat files that just don't require you to put any filters or parameters on them. You just basically dump the billing information out of your system, and doesn't involve a lot of manipulation on management's part. What we see in practice is one of the more challenging things is really being able to understand what to do with the data. And our physician practices group has been really key in helping hospitals understand what relationships don't look right, or where there's a lot of opportunity. So that's really been more of an area of challenge, and not so much on the data side. But that's a good question.
Okay. All right, thank you for that. And either you guys were extremely thorough in your presentation. Oh, there we go. Got another question. All right, this one here comes from Nicole, and it reads, how do you handle lab and radiology in service line reporting? Do you leave it as its own service line, or do you give credit to who ordered it?
Yep, and that's a great question too. So if we're talking about service line, for those sort of supporting service lines, to the extent like you come in for an x-ray before a procedure a couple days later, we tie those in so that the services provided ahead of time, so the diagnostic services get tied in with the subsequent main stay, and the physician that orders that mainstay is who gets the credit for that whole episode. So they're not viewed as individual stays; they're combined in those kind of circumstances. But that's a really good question.
All right, thank you. And our next question comes from Paul. What is your preferred method to define service lines in the outpatient services? HCPCs, diagnoses? Any insight there?
So we've developed an algorithm that looks at all those things, both billing codes and diagnostic codes and procedure codes, and kind of goes through a process to assign a claim to a service line. Inpatient obviously is very straightforward because you've got a DRG crosswalk, but the trick is on the outpatient side, and we use all those to come up with an assignment on the service line for outpatient.
All right, thank you for that. And Eric was wondering, what was the data source for the external data portion of your presentation? And I guess that's when you guys switched over. I'm sorry.
I can tell you. We as a firm, we have purchased Medicare claims detail, and so that data comes from CMS, and it's for every claim for every beneficiary across the nation, and we get that quarterly.
Perfect. All right. Looks like we're winding down here. So this last question is, we're working on a project similar to this, segregating all charges as one piece and looking at several different ancillary areas. We have the IP medical for now, but the question is, how do you look at the ancillary departments such as lab and radiology?
Yeah, and so it kind of gets back to the earlier question of, generally you don't come to a hospital necessarily just for lab or radiology. Those are used to figure out what subsequent procedure or treatment is needed, and we tie those together. Even if they're separate hospital account numbers, we can look at the data and say, well, we can see this scan was in preparation for this procedure or this other therapy, a week or so later, and we bundle that up. So to the extent we can, you do have some claims that just strictly are one of those diagnostic procedures, but to the extent they relate to a subsequent, more, telling stay, we combine them and roll them up under the main type of service.
All right. Thank you for that. Looks like we may have exhausted the questions. If there are any last minute, feel free to send them through. And as you can see, the presenters were kind enough to provide their contact information on the screen. So if you'd rather have a direct conversation with either of those gentlemen, feel free to reach out. Now, as we approach the top of the hour, I do want to take this time to thank our members and the healthcare community for joining this call. As you exit, you will be prompted with a survey, and we would really appreciate you sharing your feedback about today's event as well as other topics you would like to see in future webinars. So if there are no other questions, nope, all right. So thank you again to our guest presenters, Eric Rogers, Derek Pierce, Todd Kenny of BKD. Thank you, gentlemen, for joining us today. And on behalf of Region 8 chapters of HFMA, thank you again for joining. Have a great afternoon, everyone.